It is 4 o'clock. Hi, everybody. Welcome to this week's student-led weekly journal club. Today, I will be introducing student Dr. Kara Fadanelli. So student Dr. Fadanelli is an anatomy fellow at Kansas City University. She studied chemistry and Spanish at the University of Alabama, and she has previous research background in psychology and death acceptance. Student Dr. Fadanelli is interested in almost every specialty, but is thinking she might enjoy family medicine. Outside of the anatomy lab, student Dr. Fadanelli enjoys watching Survivor, playing board games with friends, and talking to everyone about how Michigan is the best state with the greatest lakes, and if I may add, also the best cheese curds. So with that, I will hand it over to you, student Dr. Fadanelli.
Thank you. Okay. So hi, everyone. I'm Kara Fadanelli, one of the anatomy fellows on the Joplin campus. And today I'm going to be sharing with you all my case study on a popliteal artery aneurysm. First, I want to take some time to recognize some individuals who helped make this presentation possible. My PI, Dr. Z, my co-fellows, Dr. Hillard and Dr. Martin for their pathology expertise, Dr. Brower and Dr. Withnell, the first year students assigned to Tank 6, and of course, I want to thank the MkRC Journal Club for allowing me the opportunity to present my research with you all. Here is the abstract and IBC number for the project we are about to learn more about. So unlike some previous presentations where we start by posing a question and then trying to find that answer, case studies start with a finding that you're going to get some questions from, you're going to try to find those answers, you're going to get some more questions from, and so on and so forth. So we're going to start our journey with our finding, and that is during the dissection of the posterior thigh and popliteal fossa as part of KCU's anatomy curriculum, a fusiform popliteal artery was discovered in the right popliteal fossa. At the widest location, this aneurysm measured 29.9 millimeters in diameter, a width that is 2.8 times the non-dilated artery width of 10.5 millimeters. So if this is our starting point, what do we know about the popliteal artery and popliteal artery aneurysms? Our popliteal artery originates from the superficial femoral artery after it passes through the adductor magnus hiatus. It's going to travel through our popliteal fossa and terminate into the anterior tibial artery and the tibio-peroneal trunk. Within the popliteal fossa, it's going to give off the 5 genicular branches, our superior lateral, superior medial, inferior lateral, inferior medial, and our middle genicular arteries. If we're taking a posterior approach, moving from superficial to deep, you're going to find the nerve, the vein, and then our popliteal artery. So our popliteal artery aneurysm, or a PAA, is going to be a dilation of the artery with the largest diameter being 50% greater than the original size. The 2 shapes that we're going to see with a popliteal artery are going to be saccular and fusiform. So a saccular is going to have a more asymmetric shape, whereas fusiform is more consistent throughout. So an aneurysm forms when the blood passing through the vessel finds a weakened area of that vessel wall and is going to balloon outward. Some causes for that could be atherosclerosis, hypertension, an infection from a deep wound, or genetic causes. And this is going to involve all of the layers of the vessel. Within our tunica media, or in the tunica media and tunica adventitia, that's going to provide the strength for our wall. And it's the smooth muscle inside of that media that's going to produce the extracellular matrix that consists of the elastin, the collagen, and the glycosaminoglycans. So when the ECM production and degradation is in an imbalance, that's going to weaken the mechanical integrity. And that can be due to multiple factors: immunologic, genetic factors, inflammatory. Specifically for the inflammatory response, the reactive oxygen species and the metalloproteinases are going to be degrading the elastin and collagen components. Additionally, when we have a patient who has multiple aneurysms, that does support a common systemic etiology, especially when it involves the large vessels. Our PAAs are our second most common arterial aneurysm after the abdominal aortic aneurysm, or AAA. And that makes it our most common peripheral arterial aneurysm. Our patient profile is going to look like a white male with an average age of 65. And some risk factors are going to be hypertension, atherosclerosis, smoking, connective tissue disorder, a family history of aneurysms, anything that's going to cause stress and damage to that wall. Looking at some previous studies on the PAAs, in a 2016 retrospective cohort on the prevalence of PAAs in patients with already established AAAs, 19% of those AAA patients upon a CT scan also showed to have a PAA. Now, 40% of those popliteal aneurysms had a diameter greater than 20 millimeters. And as a refresher, the diameter of the popliteal artery aneurysm in our case is 29.9 millimeters. Another study looked at the hybrid approach to a PAA repair, specifically when thromboembolic symptoms were present. And their data showed that the average popliteal aneurysm diameter was 31.2 millimeters. In 2015, a meta-analysis that involved cases spanning 2 decades and 597 cases total looked at the surgical outcomes in PAA repair. However, with all of that data, they were also able to compile a list of comorbidities. So from frequent to least frequent, we have hypertension, tobacco history, bilaterality of the aneurysm, hyperlipidemia, heart disease, and AAA. While mostly asymptomatic, our PAA can lead to acute limb-threatening ischemia or a deep vein thrombosis due to the mass effect. And that mass effect is when physical mass of our aneurysm is compressing against other structures in that fossa, specifically that popliteal vein, and thus creating an environment where a DVT can form. And so most of our previous PAA research focuses on the surgical repair outcomes instead of looking at other associated pathology. So that's why a cadaveric case study is going to provide us a unique opportunity to investigate those other possible problems, and it's not going to be at any cost to the hospital or the patient, either monetarily or in their health. So my hypothesis throughout this case study was if there is evidence of a popliteal artery aneurysm, then there may be evidence of related pathology, and we're going to explore that. For this project, I used a 75-year-old white male cadaver who measured 6 feet and 200 pounds. His cause of death was listed as chronic hypoxemic respiratory failure, and the past medical history included open heart surgery, cysts on his kidney and liver, and kidney stones. And this was our only information provided by the Gift Body program. So as a reminder, we're going to look at some of those risk factors for that popliteal artery aneurysm and how that applied to our cadaver. So our patient was at risk for developing a popliteal aneurysm due to his sex, his older age, and his race. And while it's not stated that the donor experienced atherosclerosis specifically, his history of a cabbage procedure does support this possibility. The other risk factors may have played a role in this cadaver. However, we're not able to confirm that due to the lack of the history. So in order to investigate further, our cadaver was dissected by the first-year students following Grant's dissector guide, and we followed the order of musculoskeletal, head and neck, cardiopulm, gastrointestinal, and genitourinary. When we did find a prominent finding, the dissection was paused so we could clean out the area, gather our data by using a ruler to gather measurements and taking pictures. And then if we could preserve that finding through the entire dissection, we did. However, if it had to be removed to get to the rest of the body, then it was removed. The data gathered in the study was primarily descriptive or measurements that were then compared to normal per the literature. So no statistical analyses were performed. Now we're going to walk through some of the things we found. Further investigating that popliteal artery aneurysm, In our left popliteal fossa, we dissected it for comparison, and it's shown in our leftmost image. This uncovered a second left popliteal artery. When I traced both of these arteries in that fossa, it showed a convergence of the two, so that ruled out early branching. I found surgical pins and sutures at both ends of these vessels, so the two left popliteal arteries are likely the result of a femoral popliteal bypass. And this bypass ran a length of 119 millimeters. We returned to the right popliteal fossa, and that produced a second femoral popliteal bypass, and that can be seen in our rightmost image. This bypass was immediately distal to our aneurysm, and this one ran 64 millimeters long. We opened up our aneurysm and removed the clot from inside. No lines of Zahn were noted. However, the outer edges of this clot did show a plaque-like buildup. Reviewing the rest of the musculoskeletal system, there wasn't any evidence of lower limb ischemia or any abnormal findings in our upper extremities. Additionally, the main veins used as autografts and bypass procedures, such as the great and small saphenous veins, were still intact in this cadaver, and that leads to, that indicates that the graft came from an external source. Moving to our head and neck region, our donor's basilar artery at the level of the pons measured 4.7 millimeters in diameter. Now the mean diameter is 3.17 millimeters with an upper limit of normal being 4.5. So even though our donor's artery is slightly over that normal limit, there wasn't a clear demarcation of a dilation in the vessel, so it's hard to deduce the presence of an additional aneurysm. As stated in our donor's provided medical history, dissection of the heart confirmed the coronary artery bypass graft. We also wanted to look at any valvular defects, which we didn't find any. And we also wanted to look at our ascending aorta, as that's a common location for aneurysms, particularly in connective tissue disorders. However, looking at our ascending aorta, the upper limit of normal for males over 65 is 45 millimeters in diameter. And for our donor, their diameter was 33. Looking into the GI dissections, we found a mesh spanning the majority of the anterior abdominal wall, and that can be seen in our leftmost image. It measured 257 by 238 millimeters. We also found a mesh placed in the right inguinal canal, which can be seen in our rightmost image. This was from a prior direct inguinal hernia repair. However, we also found that the bowel has herniated again, this time medially to the original mesh placement. An additional GI finding seen in our center image is the left gastric artery, which normally comes off of our celiac trunk. However, in this body, it branched off of the proper hepatic artery. With continuing dissection into the peritoneum, we located a current abdominal aortic aneurysm, along with evidence of a previous AAA repair. The present AAA that's seen in our center image measures 170 millimeters in diameter at its widest point, and it runs a length of 160 millimeters. So it involves our celiac, superior mesenteric, renal, and inferior mesenteric arteries, also known as the blood supply of the entire GI tract. Examining our previous AAA repair in our rightmost image, sutures and surgical clips were found distal to the inferior mesenteric artery to the level of the aortic bifurcation. This extends 119 millimeters, and this is in line with most AAAs forming inferior to those renal arteries. Currently, that repair site is showing two distinct dilations. We have a superior dilation measuring 75 millimeters in length, 45.5 in diameter, and the inferior dilation exists mainly on our right side of our abdominal aorta and also extends into our right common iliac artery. This measures 62 millimeters in length and 41.7 in diameter. Now, in order to provide a better idea of the size of our current AAA, This is a picture of the entire aortic vessel from our ascending aorta to the bifurcation of both common iliac arteries next to our donor's heart, revealing that this aneurysm is nearly the same size as the heart. Opening up our thoracic aorta and the abdominal aortic aneurysm confirmed atherosclerotic and thrombotic changes. Within the thoracic aorta walls, we saw a buildup of plaque about 3 to 5 millimeters diffuse throughout, and that can be seen in our top center image. Opening up our main AAA proximal to the prior repair site, we found a thrombi that exhibited lines of Zahn, and this is the characteristic layering of the lighter platelets and fibrin with darker red blood cells. And this indicates that the clots were formed before death. Our last finding was the genitourinary system, and we had bilateral polycystic kidneys, which was disclosed in patient history, but we also found a duplex ureter on the right. So we had 2 ureters coming out of our renal hilum, and they did rejoin before emptying into the bladder. So what does this all mean? Well, we went into this case study thinking that there was a possibility of other interesting conditions being present that might be related to our popliteal artery aneurysm. And I think that we succeeded in that goal. Our notable findings of our bilateral femoral popliteal bypasses and our AAA are known to be associated with PAAs. So it wasn't surprising to find them, but the size of that AAA definitely was. And this points to extensive vascular circulation complications for our patient. Some of the findings that are not commonly reported with PAAs were our hernia with the prior repair and the bilateral polycystic kidneys. So considering the great span of complications in this patient, it does warrant considering a systemic problem. Perhaps a connective tissue disorder. So I looked at 3 different connective tissue disorders. First, with Marfan, some of those key features are going to be the ectopic lens, an aortic aneurysm at the aortic root, pectus deformity, mitral valve prolapse. And in our patient, we didn't have a lot of those key features. We did have an aortic aneurysm, however, it was not at the root, it was within the abdominal aorta. Looking at Ehlers-Danlos, particularly the vascular subtype, which is the worst prognosis of all the subtypes. Those key features are going to be the joint hypermobility, skin hyperextensibility, abdominal aortic aneurysms, and mitral valve prolapse again. And so for our patient, we only had that abdominal aortic aneurysm. Now for this third connective tissue disorder, some of you may not have heard of it before because I know I hadn't until I was looking into this case study. And it's called Lloyds deets. It was first described in 2005, and it involves a mutation that affects our TGF-beta receptors, unlike the fibrillin and collagen that's involved in our Marfan and Ehlers-Danlos. The key features for Lloyds deets is going to be increased distance between the eyes, a bifid uvula or cleft palate, which is a hallmark feature, widespread aortic and arterial aneurysm, and tortuosity in our neck and head, and hernias. So again, comparing to our case study body, we did not have the bifid uvula or the cleft palate. However, we did have widespread arterial aneurysms. And additionally, I've pictured the tortuous facial artery that was on both the left and right sides of our body. And of course, we have our hernias. Now, against the case of a Lloyds deets or connective tissue disorder, in connective tissue disorders, there is a low life expectancy, particularly with Lloyds deets. Aortic aneurysms will rupture at a smaller size and at an earlier age than in Marfan, which again already has a low life expectancy. So considering that our patient is 70, it does point away from that. However, because Lloyds deets is relatively new, there still might be a possibility that there's a more mild form of that syndrome that may allow a patient to live longer. Another systemic disease that may have played a role in our case study is autosomal dominant polycystic kidney disease. As the name suggests, this is inherited in an autosomal dominant pattern. And whereas the connective tissue disorders had that low life expectancy, symptoms don't even appear in an autosomal dominant polycystic kidney disease until between the ages of 30 and 50. These key features were the kidney cysts and stones, high blood pressure, intracranial aneurysm, mitral valve prolapse, and hernias. And in that autosomal dominant polycystic kidney disease, those patients experience abdominal wall weakness that is going to lead to that herniation. Now, we know that our patient had our kidney cysts and stones per their past medical history. And an additional thing to point out here is that high blood pressure is related to ADPKD, and it's also one of those risk factors for arterial aneurysms. Looking at some of the limitations of the study, a clear limitation in a cadaveric case study is the difficulty to confirm the donor information. Was the donor aware of his reappearance of his aneurysms? Does he have a family history, or was he ever tested for connective tissue disorders? The limited donor information makes it difficult to gather concrete history to be able to answer our questions. One of the ways we could get some confirmation would be through genetic testing. However, that wasn't readily available in this study. And of the multiple aneurysms and hernias, it did have us consider a connective tissue disorder. However, because of the formalin embalmed cadaver process, it creates very inflexible limbs. So it's difficult to assess for any of that joint hyperextensibility or skin elasticity in order to confirm or point away from those disorders. And of course, in a case study, it's only based off of one individual. So while we can definitely learn from a case study and the findings are interesting, they alone can't be used to make generalizations going forward. Case studies do provide a really unique insight into the human body, and our donor had a variety of different medical problems, many of which we were able to relate back to one another. And as our first osteopathic tenet says, the body is a unit. So in the case of our donor, we can look at its listed cause of death, chronic hypoxemic respiratory failure, and we can connect it back to the major flow disruptions in the multiple arteries that would have prevented oxygen transport. Case studies allow us to explore what is left untouched and think about what otherwise we maybe would have overlooked. And therefore, they're an important part of research. For future directions for this particular project, I think a literature review would be really valuable to compile information from other case studies and again, look specifically at those associated findings, because a lot of that previous work, again, does focus on the treatment. If someone in the future were to do a case study on popliteal artery aneurysms, I would recommend making sure that all of the patient information that you have access to is available to you. And I'd also see if there was genetic testing available as well. I'll also be presenting this research as a poster presentation at the AACA annual meeting from June 13th to 17th in Fort Worth, Texas, so next week. And some journals that I'll submit a manuscript to will be the Clinical Anatomy Journal and then the American Medical Student Research Journal, and that is a journal that is authored, reviewed, and edited by medical students with faculty guidance. These were my references that I used to compile all this information. And I would love to answer any questions for you all.
Awesome. Thank you so much, student Dr. Fadanelli. Like she just said, does anyone have any questions? Feel free to unmute, go for it. If you can't unmute, feel free to type it in the chat or raise your hand on Zoom. Dr. Hillard, you got your hand raised.
Yeah, great presentation, interesting case. I was just wondering, Was there evidence of hypertensive heart disease? Did you see evidence of left ventricular hypertrophy at all? Oftentimes, if you have a hypertensive, especially a chronic hypertensive patient, you'll have left ventricular hypertrophy as the left ventricle tries to pump against that increased systemic pressure.
Right. So the heart in general, I did note that the heart was pretty diffusely large, but I did specifically look at left ventricular hypertrophy, and the size wasn't any greater compared to the other walls.
Okay, great. Thank you.
Dr. Johnston?
Kara, I'll echo Dr. Hillard's comment about your presentation. I thought it was outstanding. You were so steady, you had a good rhythm as you presented your slides, and you narrated it quite well and explained it very well, as along with the pictures. I have a few questions. First of all, it sounds like this guy was vasculopathy from the day one. And I agree with Dr. Hillard, it's unlikely, I mean, it's unusual not to have some other organ hypertrophied with that much of vascular disease. And it's the fact that the heart's a little generous, but the LV is not enlarged is surprising. Having said that, one of my questions to you is, do you know if he had any aneurysms in the brain?
So looking at the brain, the only thing that we were able to find that was remotely related to that was that enlarged basilar artery. Looking at the brain grossly, it didn't look like there was a lot of injury to it. However, I wasn't able to maintain a lot of the vessels throughout the dissection process to really be able to go through every single brain vessel and check for any aneurysm.
Okay, all right. Well, the size of that aorta is just very impressive. So he's lucky he didn't exsanguinate or pop that aorta, because that is huge. I don't think I've ever seen one quite that big. Rob or Mary Pat or Mary Jo, have you guys seen aneurysms that big in the aorta?
Actually larger.
Larger.
Yeah, I have.
Okay, that's huge. How far across is that aneurysm from diameter?
170 millimeters.
So, okay, that's a good size aneurysm. Okay, my other question was, you cited an incidence of increased incidence of DVT, and I trust that is in proximity to pressure from the popliteal aneurysm on the veins?
Yes.
Okay, all right. To your knowledge, he never had any incident of claudication or clots or embolic phenomenon distal to the aneurysm?
No, we were looking at the lower extremity in that calf area and in the feet, and we didn't find anything, nor was anything in the history that suggested.
Yeah. Well, I can certainly buy the fact that he's likely died from complications of pulmonary disease. I can see that easily. But the fact that these vessels didn't rupture is a miracle. And that was kind of found as an incidentaloma, I guess, as you were studying the lower extremity. I thought you did a very good job, and it was a good review of the literature. So nice
Thank
work.
you.
Nice work.
Dr. Martin?
Hi, Kara. A couple quick questions. You had mentioned that you thought the left ventricle was the same thickness as the other walls in the heart?
No. So the left ventricle was a little bit larger than the right ventricular wall. However, I do know that the left ventricular wall is supposed to be a little bit thicker in most individuals. And so that's why I didn't think that it was very notable.
So you didn't actually measure the thickness and compare it to the standards for left ventricular hypertrophy?
I did not.
Okay. Second question, how large were the kidneys? Were they average size or larger than average?
The kidneys did not appear to be larger than average, but I may have to go back and check my records on that.
Because a usual adult polycystic kidney disease in somebody that age should have been over a foot long. And
Okay.
yes, if it was polycystic kidney disease. So I have a little bit of trouble with you calling it a polycystic kidney instead of calling it a kidney with multiple cysts.
Okay.
And the other thing is, anytime you've got any type of aneurysm, you've always got to check the entire circle of Willis. It's mandatory to verify whether there's an aneurysm problem that's seen permeating throughout the body. Yeah, we could have probably helped you on this some if we'd been consulted.
All right, thank you.
I'm just giving you those questions because if you're going to go for a presentation, they're going to ask you those.
Yeah, I'll definitely make sure to make some changes on that.
Any other questions, comments? If not, thank you so much again, student Dr. Fadanelli. Again, just to piggyback off of that again, I thought you did an excellent job presenting as well. Good luck in Texas next weekend. That's so exciting. I'm sure you'll do great. You did great this time. So yeah, thank you everybody for joining us this weekend, or I guess this Friday. There is 4 more journal clubs left for the summer. Sorry, something popped up on my computer. There are 4 more journal club presentations left for this semester. The fall dates are open. If you go back to my email or Canvas notifications, you'll see a link to go to the kind of journal club homepage where you'll see fall dates that are open. If you or you know a student that maybe wants to present, have them click around there, let me know, and I hope to see you again next week. Thanks again, everyone.